All right, now let's move on to talk about potassium and the effect in mortality in PD patients. This was a large study that looked at 10,000 PD patients and more than 100,000 hemodialysis patients. And let me just give you a quick background about this study. Now, we know that PD patients have similar cardiovascular mortality to hemodialysis patients. That's a fact, which is known, all right? We also know that hemodialysis patients are subjected to myocardial stunning because each time we get them on the machine, we take fluid off, and there are studies that have shown with MRIs that these patients are subjected to myocardial stunning, and this is assumed to be the probable cause of higher mortality in hemodialysis patients. But that does not really happen in PD patients because PD is a slow treatment that is not really associated with any hemodynamic instability. All right? So what is it in PD patients that makes them have a similar cardiovascular mortality as hemodialysis? So these authors proposed or hypothesized that it could be because of potassium abnormalities in PD patients, which are seen more in PD rather than hemodialysis patients. Again, I guess most of us who work on PD have noticed that PD patients are much more likely to have a potassium less than 4. So they hypothesized that it could have something to do with potassium. All right. So what they found out was serum potassium had a U-shaped relationship with all-cause mortality. All right. So really, patients had, outside the range of 4 up to 5.5 serum potassium seem to have higher mortality. All right. So that's the population attributable risk for all-cause mortality. Less than 4 is not good. More than 5.5 is not good. And that could possibly explain why these PD patients are subjected to higher cardiovascular mortality. Again, this is just hypothesis, all right? But it does suggest that it may be better to keep patients at this level between 4 and 5.5. Now, is hypokalemia only correlated or possibly correlated with mortality in PD patients? And the answer is no. There was at least one study from Taiwan that have, demonstrated that people who have hypokalemia are more likely to have peritonitis, especially with these organisms, and it could be because of some, ileus or something that they develop more peritonitis. All right. So I guess we have more than one good reason to try and get the potassium level to a reasonable rate in PD patients. And how do we do that? We would do that with diet, but I want to caution people who are working, in our region, not to really encourage patients to have more dates because dates have a lot of calories and our patients are already receiving a lot of calories from their PD prescription. You could use PO, potassium chloride supplements, or you could use potassium sparing diuretics, which are mineralocorticoid receptor antagonists. And at least according to 2 studies in PD patients, those medications have been effective in treating hypokalemia, and they have shown some improvement in surrogate markers such as LV mass index and LV ejection fraction. There are 2 ongoing large trials which are looking at the effect of MRA on dialysis patients. So pending those 2 trials, I don't think it would be wise to recommend a widespread use of potassium-sparing diuretics in these patients, but they are certainly a good addition when your patient keeps having hypokalemia despite what you do. All right, now let's look at sodium level. Is there any problem with the sodium level? Could that be correlated with mortality as well? And this was prompted by the fact that there are a lot of observational studies that have shown hyponatremia to be correlated with higher mortality in non-dialysis patients. All right, so what these investigators did, when they looked at over 4,500 adult incident PD patients, and they correlated their serum sodium with mortality. And what they found was serum sodium that is less than 140 to 142 range was associated with a progressive rise in mortality, whereas higher sodium did not really do that. And they hypothesized that the possible mechanisms by which these patients could have higher mortality, it may have to do with CNS problems, again, from extrapolation from non-dialysis patients, CNS problems, CV derangements, cardiovascular derangements, high likelihood of infection. Observational studies have correlated hyponatremia with those. So maybe that's why, all right? So when you see PD patients who have persistently low sodium, especially less than 135, what I usually do is I advise them to restrict water, and fluid intake, in addition to salt intake. All right. So low sodium usually indicates excessive fluid intake in dialysis patients.